Today and the next week will be about rhinology. So essentially, some of you already know this. I've been working with Ms. Jaithwal on developing the outpatient rhinology pathways as part of the GIRF, and which is getting it right the first time, trying to enhance our efficiency out in the outpatient setting, and also aiming to try to get one-stop clinics, so to just reduce waiting times and I guess improve our efficiency. So this is going to be implemented here at MRI starting actually September, and some of you will be involved in these clinics as part of your new rotation. So we thought we'd do some teaching about rhinology and how to manage patients in an outpatient setting, and also introduce the pathways to you as well. Okay, so some of this will, I know some of you have not done ENT before, so it'll be very basic. And we want to make this interactive, so please interrupt me if you have any questions. So hopefully after the next couple of seconds, you'll be able to, obtain a full history and do basic rhinology examination, and also understand the role of different investigation modalities that we do in rhinology, and then hopefully able to formulate management plans for patients in an outpatient setting. And also you could use that in an emergency setting, I guess. Let's talk about history taking. What are the key things you want to know from a patient presenting to your rhinology clinic? Yeah. So obviously the presenting complaint, but what are the key points that you want? What are the key complaints that you want to cover as part of your history taking?
Not now.
Yeah. So nasal obstruction. Yeah, nasal obstruction. Obviously, every symptom we want to analyze this, right? So the duration, course. Nasal obstruction, is it unilateral, bilateral, persistent, is it intermittent? Yeah. Okay, so we said nasal obstruction, nasal discharge.
No.
Yeah, so smell problem. Smell problems could be anosmia. What else? Other smell problems? Yeah, bleeding. So going back to the smell, what other smell problems could they present with?
Then urological feature.
Yeah. Yeah, so hyposmia. So smell problems could be hyposmia, anosmia. So you have to, certify what is the problem exactly. That's just a diminished or just absolute loss of sense of smell. Caposmia, you've got like a sense of smell. Right. Bleeding, you said bleeding. Yeah. What is the discharge?
Any trauma for deformity?
Yeah. The traumas.
Past medical history, if it's accompanied with asthma,
Yeah.
any allergy with aspirin.
Very nice. Yeah. If anyone wants to share in Teams, just joining us virtually as well, unmute yourself and share. Anything else? Yeah. Yeah, so essentially we've covered, nasal obstruction, nasal discharge, the smell problems, facial pain. Lots of our patients coming to rhinology, they come present with facial pain. And, it could be facial pain headaches. We need to know whether that could be a sinogenic origin or a migraine or, different types of atypical facial pain. A very huge proportion of our patients come with rhinitis, and that can come with other secondary symptoms of allergies like sneezing, itching, watery eyes. And then red flags. Right, so what are the red flag symptoms in rhinology? Mostly unilateral symptoms. Yeah.
Recurrent bleeding.
Yeah. Mm-hmm.
Oh, it's right.
Correct.
Let's think about sinonasal malignancies. Right.
Progressive obstruction.
Yeah.
Progressive obstruction.
Yeah. Sinonasal malignancies could be arising from maxillary sinus. So you think about sinonasal malignancies originating from the maxillary sinus. Patients can present with loose teeth. You think about ethmoidal nasal cavity. they can go into the orbit. So that's why it's really important to also cover these symptoms. Whether they've got diplopia or any eye symptoms, intracranial symptoms obviously can be a sign of red flag. It's a very advanced disease. Okay, so that's part of the presenting complaints. What about the past medical history? What are the key points we want to cover? Yeah, so the medical comorbidities, so asthma and rhinitis is very
Allergies.
Yeah, allergies. So
Previous personal history of conflict.
Previous history of surgery, nasal surgery, sinus surgery.
exactly, well done. Previous history of trauma, you're saying, for those presenting with the structural problems, maybe obstruction, block notes. Yeah. So we've covered most of the things, but medical conditions of relevance, things like vasculitis. Patients with vasculitis or any condition that will present with nasal symptoms, and this is something that we have to be put it in the back of our minds. When you see a patient, because they can just present initially to the rhinology, and this is when we have to pick up the concern that they might be underlying vasculitis, and we need to refer them to a rheumatologist. Obviously, asthma, eczema, and atopy. History of traumas, as we mentioned, and not just trauma, so also nose picking.
Smoking.
Yeah, so in terms of social history, smoking, the use of cocaine, specifically, if you're concerned about this, always ask about cocaine. Occupation, and also whether they've got pets, especially those presenting with rhinitis. We talked about allergies, hay fever, whether they've had previous allergy testing. The other thing that we haven't is very important is the medications, what medications they're taking. Whether they've used any nasal steroids in the past, and how compliant were they on the nasal steroids, whether they've been using local decongestants. Obviously, that causes lots of issues if they use it long term. And those presenting with other structural nasal obstruction, with some cosmetic concerns, one of the things we think about whether they've got body dysmorphic features and realistic expectations. Before we consider them for any operations like rhinoplasty. Another thing that's really important is using the patient outcome measures, and you'll see when I present the pathways, we're trying to integrate these into our practice. These are the three most common patient-reported outcome measures, and this is a way that we can assess how bad the patients present to us initially, and then can evaluate our treatment. So those presenting with sinus disease, we use SMOC22. Those with rhinitis, we use the visual analog score. And nasal obstruction, use the nose score, and hopefully they will be. The plan is to integrate them onto eyes. When you see a patient in a clinic, you use these scores and you see the pre and post intervention or treatment. Right. So how do we examine them? Any other questions about history before we move on to examination? Okay. So.
Not with inspection.
Yeah.
Any on the nose, any deviation of the structure from the midplane of the face.
Yeah.
Any other more features of the face.
Nice. We always have to look at the nose, the harmony in relation to the face. Yeah.
Any swelling, perichondritis features of the
skin to skin.
Cartilage of
look at the skin. Yeah.
Skin, yeah. Any skin cancer.
Yeah. Yeah. Okay, so inspection, we generally, when we inspect patients, we look at them at different views, so frontal, lateral, and basal views. This is, so those who, this is a little bit more advanced. I'm not going to go into too much details about this, but those who will be, if there's any registrar joining the teaching or be looking at that presentation, there are sometimes important landmarks where you need to know just the terminology, and this is quite important for the FRCS exam. So essentially, we do, as you said, full inspection. One of the things that we will be looking at on a frontal view is we look at, as you said, Demetrius, we look at the entire facial structures in relation to the nose, to the rest of the face, and the harmony. There's a line called the brow tip aesthetic line. Can you see the marker? Can you see it? Not in there. Okay. Essentially, it's just a line that goes from the brow all the way to the nasal tip, and it is useful to identify any irregularities along the lateral, the side of the nose. This is a very common terminology that you have to use when you're making your assessment. And on the frontal view, and on the lateral view, what you're looking at, there are certain important angles. So before we go to the angles, as we said with the inspection, you look at the nose, you divide the nose into fifths horizontally and vertical thirds. And this is how you assess if there's any facial asymmetry. So essentially, again, on C, so essentially that these thirds from the tricone all the way to the glabella. Tricone is where the hairline is. Should be equal to the area between the glabella to the subnasal, and then the subnasal to the menton. And then the rule of the fifth, which is horizontally, again, the width of the eyes should be equal to the distance between the intercanthal distance, and then to the and then laterally there. Yeah. And then important things to look at in the lateral view. We look on different angles in terms of the nasal frontal angle, which is the image here on the left, and that's roughly between 115 to 135. And then we also look at the nasal rotation, the nasal projection. These are very important things we look at on the lateral view. The nasal rotation is the nasolabial angle, and it's between 95 to 110, and very obviously if it's a male and female. And then the nasal projection is how far the nose projects from the face. And the most common method to measure this is something called Goods ratio. And the way we measure this is essentially a line drawn from the alar facial group to the nasal tip, and that's 0.55 to 0.6 to the distance from the root of the nose all the way to the nasal tip, and that measures the nasal projection. When you see a patient and then you're describing the deformity, you talk about whether the nose is under-projected, over-projected, under-rotated, over-rotated. These are the kind of the terminology that we use. Okay. So let's go on to the actual, then after the inspection, obviously you need a good light source, and then you start inspecting, you start palpating the nose, palpating the nasal dorsum. Obviously, if it's a patient coming with trauma, you can feel step deformity, you can feel any irregularities, if there's any tenderness. And a very important thing when you're doing any assessment is also you feel the tip. You palpate against the tip and you see this is an indication to give you about how good the tip support is and how good the structure of the septum is. The patients with a very poor tip support, someone's coming with nasal obstruction, and you see clinically, the septum looks central, but then you press on the nose and it just squashes all the way to the face. This indicates that they have a very poor tip support. That's what we call that they are a cartilage depleted nose. And you have to think about this if you're listing them for any set rhinoplasty, and if they don't have like endogenous cartilage, we have to think about either cartilage grafts or different grafts, whether best would be the rib cartilage. So this is a very important point in the examination, is to feel that tip support. Okay. And then using the subicon speculum to do an anterior rhinoscopy. Remember, before doing this, you need to just lift the tip of the nose, because if there's anything in the vestibule, once you put the speculum in, you won't be able to see what's there. So things like, for example, septal hematoma or a full dislocation or any lesions within the vestibule, then you can easily miss that if you just put the speculum straight away. So remember just to lift the tip and then have a look and then do the anterior rhinoscopy. So what are we looking at when we're doing the anterior rhinoscopy?
We're looking for the septal deviation, the inferior turbinate.
So this is right.
Inferior nasal meatus.
So essentially, you look at the nasal septum, whether it's deviated. You can see the inferior turbinate as well. Sometimes you can see a middle turbinate, and it's very common that you get a referral and you say there's a nasal polyp. is people have seen part of the middle turbinate and they think that's a solid. So you can see the middle turbinate sometimes on anterior endoscopy. So you come in and look at the inferior turbinate, whether it's hypertrophied, you can see whether there's discharge in the nasal cavity, any rhinitis. Look at the nasal mucosa as well, whether there's any common vessels in this area, someone's coming with epistaxis, or if there's any rhinitic changes to the nasal mucosa, someone with allergies. And you can also sometimes see, grade 2 or grade 4 polyps, which is polyps coming all the way up to the nasal cavity.
Very important.
And obviously, like foreign bodies, yeah. Okay. And so following this, obviously, one of the things to do as well is called a modified polyp test. You know what that is? A modified polyp test is essentially, so sometimes you can see a patient, and you look at them, there's nothing. Septum looks central, everything looks fine. They're still containing a nasal obstruction. And it's because they have weakness on the side walls of the nose, in the nasal valve. And what happens is that when they breathe in, that will collapse. It's very important as well when you're doing as part of the examination of the infection, you ask them to breathe in. And you see how the side wall, if it's collapsing or not. And then you do that test where you put something to support the internal nasal valve, so against the upper lateral cartilage or against the side wall of the nose inside, and then ask them to breathe and see whether they. So this is another way to do it. Yeah. The modified color test is more accurate, where you do this where you put a Jobson horn probe, for example, inside the nose, and you just lift the side wall, and this gives you an indication whether they've got problems with their internal nasal valve. Modified Cottle test.
Cottle test, yes.
So this is the modified Cottle test.
It's right, like the Cottle incision.
COTTL. So you ask them to breathe and sniff in. Yeah, if you type it on, I don't have a video of it, sorry, but if you
on YouTube,
you see them, that's all collapsing inside. So that's also another important part of the examination. Then the main
valve,
yeah, exactly.
To check.
And I guess the main thing is obviously nasal endoscopy. So I think we should everyone who comes to the rhinology clinic has a in my practice, I think everyone who comes to the rhinology clinic are most always with scoping. There's something quickly that you do in the clinic, and there's so much information you get with the endoscopy. And it's slightly different to the way we do when you're doing a nasal endoscopy for a head and neck patient. You go quickly through the nasal cavity. But if you're doing it in a rhinology clinic, or someone coming with a rhinology complaint, it's a little bit different. And I'll just show you that video and explain how we do it. And also, this is how we do it as part of the doing like an EUA under general anesthetic. This is how we do a full EUA. The video is working all right. So it's called the 3-pass technique. So the first pass is we go through the nasal floor, go all the way to the nasopharynx. So here, this is the faces. Obviously, it's got a 30-degree scope. And by moving that light cable, it's moving the bevel of the 30-degree scope, you can see all around, and that's the nasopharynx. See the station tube opening. And then you also look on the inferior meatus, so that's the space below the inferior turbinate, where the nasolacrimal duct opens. And you can see here it's palpating, it's probing the lacrimal tract, and you can see where the nasolacrimal duct is. Sometimes you can see here's there. This is the first pass. And then the second pass, we go medial to the middle turbinate. And this is when you can see the opening from up here. You can see there the opening of the sphenoid sinus. You're looking at the sphenoid recess. And then the third pass, you go lateral to the middle turbinate. Obviously, because the patient is asleep, so it's using instruments. But the key to the assessment, you can do that for the flexible, but the key with the assessment is you need to, for every patient, I don't know, we don't use generally blue sprays to decongest in any size nose for head and neck patients. But I think it's a must for in rhinology patients because you won't be able to get through the, it'd be quite painful. So let's have a look at different pathologies. So you can see, obviously, you can see pus. patients with acute rhinosinusitis on the picture on the top left. And then here, that picture there. See the
Which
cursor.
picture you are
Oh, you can't see the cursor. So let's say the middle one there.
Is the one in
Oh, see that works. Is that working? Can you see
Yeah.
that? All right. What can you see here now? That's
okay.
There's a polyp there.
yeah, so nasal polyp. There's a nasal polyp. So usually the polyps, obviously if it's someone with chronic rhinosinusitis with an allergic nasal polypi, you find the polyps will be pale, slightly blue, they say in textbooks, but usually they are pale when you compare them to the rest of the nasal mucosa. If you see, these are all like inflammatory allergic polyps. If you see like obviously a fleshy, red, irregular mass, then that's more suspicious of malignancy. What about this picture here? Pointing using both on both.
There's a spore.
Yeah. So which nasal cavity is that one?
It's the left
Why is it the left?
because the septum is on the middle.
Yeah. Well done, Jimmy. So the lateral nasal wall, you can see the inferior curve in it. That's the left nasal cavity, and that's just a septal spur. You can see that will be affecting the airway, even though it's just a minimal spur. And it's just almost touching the inferior turbinate of the lateral wall. What about this picture?
I can't see the adhesions.
Lots of adhesions, right? Lots of crusting.
Yeah.
What about here? What's going on here there?
There is
Got
a
a septal perforation.
perforation.
What
Yeah.
about here?
The adhesion.
How about this one? Possibly that could be a hole into the floor of the nose.
Maybe post-op or
So yeah.
vasculitis.
So this
Post-op.
is vasculitis, cocaine. This is how it.
Post-operatively you can get the adhesions as well.
Yeah, but that crusting and all that destruction, and there's no mass or anything, so that you think about vasculitis or whether it's cocaine induced. What about this here? Where's that?
Okay.
In the nasal cavity. Yeah, so it is postnasal.
Yeah.
But you see, it's more to one side and it's blocking the fossa of the molar. Yeah,
Juvenile.
yeah, well, SCC. Nasopharyngeal SCC.
Juvenile, how do you call it?
Angiofibroma, is that what you're thinking?
Juvenile.
Angiofibroma.
Angiofibroma.
Right, investigation. So we've got lab. You can request the patients in clinic. Obviously, yeah. What is RAS? You said RAS. What is RAS?
The skin test for the.
So the skin prick test is the skin prick test for allergy. So what is RAS?
It's not for the allergies.
Yeah, it is for the allergy. So what is it? Is it a blood test or the skin prick test?
It's a blood test for the.
Yeah. So it is a blood test. It's different. It's a blood test. And what does it measure?
IG.
Yeah, it measures specific IgE to a specific allergen. When you do a RAS panel, you get you get the grass, the pollen, dog scats, stuff. Yeah, so the RAS is a panel where you look at the specific IgE. Radio allergy or sodium testing. That's what it stands for. Just thought I'd put that there. So if someone's got CSF leak, what's the name? You know what the name is? Because you can see that quite a lot in other post. Yeah. Yeah. Also called as tau protein. So this is a very big end of that. So might be looking at these lectures for examination. Quite common question in exam. Right. What about radiology? What about radiology? So CT scan, the mainstay. Most of our patients. Sorry.
Oh, sorry, I just said CT scan of the sinuses.
Yes, that's great. Thanks, Sophie. So CT scans obviously is the mainstay. For any sinonasal, obviously for sinonasal like sinusitis. And obviously, it's useful to look at generally CT scans to assess the bones. And you guys are all familiar with CT scans of the science, so you want to go through it quickly. Okay. I can go through it quickly at the end with I've got because I've got just because this is just one cut. So if you look at this one cut, this is obviously the maxillary sinus. Here the nasal septum, and when you look at the scan, you always have to think about that what window. This is a coronal cut, and it's a bone window. Okay, you can see the bones right there. The soft tissue window where we sometimes can use it. Also, most of the time we look at bone windows for CT scans, the sinuses, but in certain situations we look at the soft tissue window as well. For example, if you want to look at, if you want to rule out like fungal sinusitis or patients like complicated sinusitis, and you're thinking of whether there's any abscess, abscess, for example. And then obviously this is the nasal septum. I'm trying to use both pierces at the same time. And then that's the middle turbinate there. And it's just the cribriform plate. Obviously this is the orbit. I'll go through the CT scan at the end. If we've got time, we can go through the CT scan, different views. And then when do we request MRI scan? Yeah. Why? Yeah, exactly. Because we've got better soft tissue. So if you've got, because let's say if you've got someone with a sinonasal malignancy, you do a CT scan, it will just look as if it's like a soft tissue opacification in the sinuses. There will be some bone destruction, of course, but sometimes it's difficult to say whether it's going into orbit, whether it's going into brain, and that can change the staging, and therefore change the management, of course. So the MRI is then useful. Every time you see a scan, we check there's anything going into the orbit or into the brain, MRI scan is useful because it assesses orbital and intracranial involvement. What else do we when do we request CT? When do we request MRI scan as well? For the condition? I mean, if someone, for example, CSF leaks, quite useful on T2 weighted images because you can sometimes see the CSF and see in T2 because it will be bright signal on T2.
In angio when you say juvenile.
Yes. Yeah. Let's go through some CT scan images. So look at that scan on the left, and if you compare it to the right, what do you think is going on the right, and what do you think is going on the left?
It's the same person.
No, it's not the same person, obviously, because it's right and left. Okay. Let's see. Yeah. So what is happening here? Yeah. Do you think is that? Yeah. How does it look? Look at the bone.
Yeah.
Is that more of an expansion or is it more of an invasion? Expansion, right? How about here? Yeah. So lots of bone destruction, right? So this is probably a mass causing a bone destruction, but that is probably a mucocele. You can see even the lamina just pushed there, and all the muscles. I don't know if it's clear on the screen. Yeah, it's not like. But obviously here we'll get an MR, but this looks behaving more like something expanding. So it's more of a mucocele that just causes expansion over time. Whereas here you can see the destruction. Yeah.
Okay, come here. I've just got a tiny bit to do there, mate. In corner, I can clean the job out.
We finish in 20 minutes.
Yeah, okay. All right.
Thank you.
See you, mate.
Check it here, guys, because it's.
What about this? This is an MRI scan. So this is another useful use for the MRI scan because sometimes you can define the extent of what is tumor and what is secretion. If you look at it, if this is a CT scan, it will all just be a soft tissue classification. But this is now not something that's like it's invading orbit or anything. But if you look at the tumor, the solid component, you can then know that this is the solid component of the mass, whereas this is all secretion.
Yeah.
So again, this is one of the useful
Okay.
uses of the MRI scan. And as we were talking, if you look at that picture here, there's a nasal malignancy, and you can see the intracranial involvement very clearly on the MRI scan, with brain parenchymal involvement, and also very useful. More importantly, in certain tumors, you can see that neural enhancement. Again, suggestive of intracranial involvement, and you can't see that in a CT scan. You guys know what this is? It should be a spot diagnosis. I don't know, but it might be a bit too advanced. I don't know if there's any registrars here. This is the same patient name, by the way. So let's describe this. On the left side, this is an axial CT scan, right? We've got soft tissue classification involving the right maxillary sinus, filling the nasal cavity, and probably extending a little bit into the postnasal space, right? And then when we did an MRI scan, again, this is the extent of the pathology. And on the CT scan, you can see the arrow. I mean, you can see the arrow here. Bit of a osteotic area. This is an inverted papilloma. An inverted papilloma that has on the MRI this cribriform striated pattern, and then on the CT scan it will have some osteotic changes, probably where it's originating. This is an inverted papilloma, which is like a locally aggressive pathology that can differentiate into SCC. Another thing just to cover quickly, when we're looking at CT scans preoperatively before an operation, there's a mnemonic called CLOSE. You can't hear it before. So what does it stand for? So we look at these are the certain anatomical areas that you want to look at. There's lots of variations, and the implications about certain variations, if you're not careful, if you don't identify them preoperatively, this is where you can run into complications. So we look at the crib. So CLOSE stands for C for cribriform plate, and it's best assessed on a coronal view, where we look at the depth of the skull gate and olfactory fossa. It's classified with Kiros into 3 types, actually 4, with the 4th being asymmetric. So the type 4, you're more likely to cause, if you're not careful, you're more likely to cause damage to the cribriform plate leading to CSF. Look at the lamina capricea. You look at the for L. Again, you're looking whether there's any orbital collapse into the ethmoidal cells, how the Onseneth process is attaching to the orbital wall. And O is for Onodi cell. Have you heard of the Onodi cell? What's the significance of it? What's the significance of having it? Opposed to, yes, opposed to the optic nerve. Other important thing is you look at the sphenoid sinus pneumatization, different patterns of sphenoid sinus pneumatization, whether sometimes it's too pneumatized, you can find the adjacents in the carotid and the optic canal. And then you look at the anterior ethmoidal artery. I'll show you just some few. This is what we were talking about in terms of the Kiros classification, looking at the ethmoidal configuration and the depth of the olfactory fossa. Got type A. This is the safest one, because you can see you see that area here is the lateral lamella of the cribriform plate, and this is where the thinnest part. So this is the part that's more likely to be injured. So got a very deep one like here. So the chances of injury would increase in a type C rather than type 1. The depth is between 8 to 16 millimeters. Majority of people will be a type 2 or a type B. The most serious one is the type D, because it's asymmetrical. So you have to identify this, because let's say if you start operating on that side, and then visually in your head you know that the skull base is at a certain level, On the other side, because it's asymmetric, you can easily again injure skull base on that side. So this is the only cell we're talking about. So this is the, you see it on the corner view. So this is again the CT scan. This is the goina there. This is the inferior turbinate at the back. You can see this is the sphenoid sinus. Okay, and that's an only cell. That's just the most posterior ethmoid air cell. You can see how closely it is related to the optic nerve. The air cell, this air cell here, defining it here. Can you see it's that air cell here? So this is the sphenoid sinus on the right and left. So that's the only cell, and you can see how it's closely related to the optic. Talked about anterior ethmoidal artery. So usually it runs within the skull base. Sometimes if there's again supraorbital ethmoidal air cell causing that pneumatization there, look, you'll see that sign. You know the name of the sign? So whereas so this is the anterior ethmoidal artery. So now we have to be careful when we're doing your endoscopic sinus surgery. Yeah, Kennedy's nipple. All right, let's look at the pathway. So this is the first part of the presentation. So let's show you the pathways. So as I mentioned, this was part of the growth pathway. I believe that's, you can see that clearly.
Yeah.
Can you see it clearly? So we've developed two pathways. The blocked nose pathway, patients coming in with a blocked nose, and patients coming in with chronic rhinosinusitis because it's slightly different management. So this is what's going to be implemented in the next month, hopefully, at MRI. So patients coming with referred with a blocked nose by the GP would be triaged into a telephone consultation, start with, and then the telephone consultation would probably be done by the SHOs or physician associates or registrars. And then at that point, we would probably, based on the, your history taking, you can probably try to appreciate some of them will be mixed, having alleviated septum and also rhinitis, but we'll try to classify them into each pathway. So if someone with rhinitis, I'm going to talk about rhinitis specifically today, but if, let's say, deviated septum is easier. So if someone coming with this, let's say GP referral says got a deviated septum examination, the history taking is all suggestive of someone who had maybe a trauma, got a unilateral persistent nasal obstruction, more likely to be a deviated septum. So we'll get them onto a one-stop clinic where they will be examined, they'll have a nose, that's always I talk about patient report outcome measures. And then they'll either be just listed for a septoplasty or septorhinoplasty, depending if there's any other cosmetic concerns or if there's any external deformities that are contributing to the nasal obstruction. And at that point, if they're listed, we'll send them for photography and possibly psychological referral if there's any concerns during the assessment. Or, when we examine them, they're not candidates for any surgery, or they discharge them, or they might then fall into one of the other pathways. Hopefully, once they're listed, so that's just a one-stop clinic. And then, if they're listed for surgery, they come for a day-case operation, and then they get their follow-up. And then, in their follow-up appointments, we do a post-op patient-reported outcome measure, which is nose, and then hopefully discharge. Okay. So today, I thought we can talk a little bit more about rhinitis and about the management, and I'll come to the pathway later. And then we've got another one on the sinusitis, which we can cover next time. So what is rhinitis? Chronic rhinitis, we define it as symptomatic inflammation beneath the mucosa with the presence of at least terminal symptoms, nasal obstruction, rhinorrhea, sneezing, or itchy nose for more than 12 weeks. Majority can you guys see the not moving, is it? Moving. I'm thinking about the computer. Yeah. So chronic rhinitis can be defined into three main categories. So it could be infectious. Obviously, for infectious rhinitis, they'll have discolored secretion, they can have some crusting, history of upper respiratory tract infection, temperature, and majority of patients will be allergic. So how do we identify these allergic patients? The history, again, will be very suggestive, but the key difference between allergic and non-allergic rhinitis is that they have got early onset, usually associated with other, things like eczema and asthma. There's usually a seasonal variation to the symptoms, and then they've got positive allergy testing. Whereas those with non-allergic rhinitis, they won't have, or non-infectious, they won't have any clinical signs of infection or allergies, and will have probably symptoms always around the negative allergy. Non-allergic rhinitis, they could be, various subtypes. Benign rhinitis, patients above 65 years of age will have a runny nose, gustatory rhinitis, occupational rhinitis as part of their occupation. Usually management of that is probably a bit of allergic avoidance. Hormonal induced rhinitis, pregnant ladies, usually they get some blocked nose and rhinitis as part of the hormonal changes in pregnancy. Drug-induced rhinitis, medications can cause drug-induced rhinitis.
Okay.
Right?
Okay.
Exactly. Ultrasound. So that's why I remember when we talked about history taking, it's been asked them whether they're using any local decongestant. And then idiopathic rhinitis. I have to change it now. So this is these. I don't know why it's not showing, but this should be. So at this point, so these should be circled around here. So essentially, what I wanted to say here from that slide is that there's very often that there will be mixed patients coming with mixed rhinitis, where they've got a bit of allergy, and then they can have an infection, or maybe non-allergic, and then they're allergic rhinitis, and then pregnancy symptoms will get worse. So it's, most of the time, it's actually a mixed rhinitis. Very confusing now. Can you both? Okay. So let's focus on allergic rhinitis. So as we're saying, allergic rhinitis is caused by triggered by an allergic reaction. Whether it's pollen, dust mites, mold, dander, and it has a significant impact on the quality of life of patients. And up to allergic rhinitis is estimated to be affecting about 30% of the European population. It can affect children, as I said, it's usually early onset, adolescents, and adults. And there's an increased risks of these patients developing asthma, and that then promotes the theory of it being a unified airway, where essentially your upper and lower airway is just one system, has the same epithelial lining, so it will react to similar allergens. And there's been lots of studies on the impact of allergic rhinitis on control of asthma. And if you look at that study, they looked at the odds ratio of you being a smoker. This is predicting the poor asthma control. If you're a smoker, the odds ratio of having poor asthma control is 4.3. So if you've got significant rhinitis, it's actually 4.61, which shows how rhinitis, allergic rhinitis, can have a severe impact on asthma control. Yeah. So what are the symptoms? Symptoms that will be suggested for. Luckily, it hasn't. The bacteria hasn't been shown. So symptoms that would be suggestive for allergic rhinitis. Again, 2 or more symptoms for more than 1 hour most of the day. So it will be like runny nose, sneezing, itching, nasal obstruction. They can have ocular symptoms as well, like redness, itching, and tearing. And then these are the symptoms that would be less suggestive of allergic rhinitis. So again, to have that in mind when you're doing the telephone consultation. got unilateral symptoms or recurrent epistaxis, so this is less likely to be allergic. Right, probably be another pathology. How we classify allergic rhinitis? So it's classified according to the area guidelines. So it's defined into intermittent or persistent. So this is when you've got symptoms less than 4 days a week or less than 4 weeks at the episode. Persistent when it's having more than 4 days a week, or the episode lasts for more than 4 weeks. And it's also classified into mild and then moderate to severe. So essentially, mild and moderate to severe is how it affects the quality of life. But it affects sleep, daily activity, work, and so that's how we classify our patients with allergic rhinitis. And then to assess the impact of the symptoms, we use the visual analog score from 0 to 10. Patients saying, how troublesome their symptoms are. And again, as I mentioned, key symptoms are congestion, itching, rhinorrhea, and obstruction. And how we look at the control, whether they're controlled and uncontrolled with the medications. So if it's got the visual analog score more than 5, then it's uncontrolled. What are our treatment strategies generally? And then I'll go on to the pathway and what we're doing, what we're trying to do. So,
Amr, please, can I ask a question?
Yeah, sure, ahead.
So, regarding the questionnaire or the doctor's page, patient page you mentioned in the last slide, are we sticking to this in our history taking and examination? Because this is I feel it's quite confusing. Or what do you think? How can we implement that in our practice?
So this is why we want to implement the patient-reported outcome measures, because it gives you a bit of a more a bit of a more perspective into how much the patients are complaining. So in your history taking, you can ask them, you let them fill in the questionnaire, and hopefully that will be integrated in HIVE as well. This is what we're working on. But then you can tell from the history how much it's impacting their quality of life. So these are key questions I believe that we have to cover. Thinking, going back here to that, whether it's affecting, the daily activities, affecting them at work, school, and you try to just get an idea whether their symptoms are intermittent or persistent. So you can easily ask about this in the history taking, and then the patient-reported outcome measures. That will be the visual analog score. It will just be questionnaire that they fill in, and they can fill in when they're sitting, in the waiting room. And with HIVE, hopefully once it's integrated into HIVE, we can then even per telephone consultation, we can send it out with the clinic letter. Does that answer your question?
Good. I agree. This would be a good idea because this will guide us through stepping down to
so this is
medication,
what,
right?
Yeah, this is obviously, it's still work in progress, but this is what me and Ms. Jaiswal are working on at the moment, that we're trying to integrate that into HIVE so that we can use them. But for the meantime, as we start the clinics, we'll have printouts of all the prompts. And
Thank you.
Even within show, some of our colleagues, you can use that even in the clinic. I think it's very useful to have. It's a very useful measure to assess how severe the patient condition is, and then also it's a way to assess how effective your treatment is.
Is it currently being used in all the clinics?
In all the clinics.
Yeah. Is it just a preference thing?
What do you mean? Which clinic?
Investigation, like you want to incorporate it into HIVE
Yeah.
or letter, but currently in the clinics, is it something that is used?
No, it's not. But what you'll find is, because most of the clinics, since COVID, most of the clinics have been run by consultants, so they already ask these questions and they get an idea. They automatically, because of their experience, they classify. They know whether the patient's got severe symptoms and whatnot, and then they can. But it's now implementing these clinics, and junior doctors will be doing this. So it's a useful way that we all do the same thing. So that then it's going to be very useful for us to audit our practice and also to research opportunities in the future. So we've got a unified system to work on. So going back to treatment strategies, because as we mentioned, it's all triggered by allergen exposure. So reducing allergen exposure is useful. Obviously, there are certain allergens that you can't really avoid, like pollen. But then house dust mites and things like that. So there are certain things that you can advise patients. There are lots of patient information leaflets online that they can refer to in terms of reducing the burden and of the allergen load. Obviously, some people will be allergic to cats and dogs, but they won't let go of their pets. But things that what they can do is obviously trying to avoid. And they found that most of the saliva of the pets that would trigger the allergy. So if you at least not sleep in the same room and things like that. So these are things that can help, reducing the allergen exposure. And then drug therapy. So we've got pharmacological therapy, and then we've got immunotherapy. And there's also monoclonal antibodies, anti-IgE, but they're very expensive, so they're not being used. And then surgery. So again, the ARIA guidelines is the reference for to quote Haytham, for the exams and them. So essentially, this is the ARIA guidelines, and it classifies them again. Remember, to intermittent and persistent, mild, moderate, severe. And essentially, for mild intermittent symptoms, they can just start with oral or local antihistamines. Then it becomes moderate to severe, intermittent, or mild persistent. You start adding intranasal steroids. And obviously, moderate to severe, then you look into increasing the doses of intranasal steroids. You can consider giving oral steroids sometimes, especially for those with having a really blocked nose. There's lots of rhinorrhea. You can think about adding something like ipratropium bromide for rhinorrhea. As mentioned, if the blockage is the persistent symptom, you can consider even giving a short course of oral steroids. And if all of that fails, you think about whether they could be a candidate for immunotherapy and the role of surgery. And this is just a table to look at the different pharmacological treatments and their effect on allergy. You can see there's lots of things, but the majority of our treatments that we actually use at the moment is just focusing on antihistamines and steroids. And you see here that they are the most effective. So you can see that oral antihistamine, because histamine is very early in the allergic phase, so it's more likely to drive the symptoms of sneezing and itching and the discharge. So it's quite effective there, but it's not really effective for someone who's got a really blocked nose. And you'll see that obviously the steroids have got the upper hand, and so the mainstay treatment is steroids. And because steroids is very comparable to oral steroids, but with a much higher safety profiles. That's why we're using mainstay treatment for allergic rhinitis is the intranasal steroid. And there's a preparation called the Nista. The Nista, so it's a combination of intranasal steroids with an intranasal antihistamine. And this is a study that looked at the time course of improvement of their reflective, use a different outcome, which is the reflective total nasal symptom score in that study. This was published in 2010, and you can see the effect here of use of the Nista. So this is fluticasone, this is steroids, avalastine is the antihistamine, and placebo. And you can see how significantly the Nista is compared to when you combine these two together in terms of the symptoms. So
the promotion for the Nista. We charge it.
It's available. It's something that we can.
Yeah, the Nista. So if you've got someone who's got severe symptoms, and they've tried, let's say the GP have tried them on intranasal steroids, then what you can upgrade it for the Nista. So then it's in here. And then next is immunotherapy. And obviously, immunotherapy has revolutionized, patients who've got really poor quality of life because of allergic rhinitis. Because all the pharmacological therapy we're talking about aims to block the inflammatory mediators of allergy, but immunotherapy actually modifies the disease. So all the other treatments aim to reduce, the symptoms, but with immunotherapy can actually it's only treatment with disease modifying capacity. And how it works is as I was saying, if we look at here, the most guidelines, even with treatment, up to 40% will remain uncontrolled. But those who've had immunotherapy, they can reach up to 84% of control on immunotherapy, with cases of severe cases. And the way immunotherapy works is that it promotes and modifies the B cell response. They're producing IgG4, which is a blocking antibody that blocks the formation of the allergen IgE complex. It binds to the allergen instead of the IgE to prevent that complex formation that drives the inflammatory mediators of allergy.
Who has access to research? It's very intelligent. Can you refer to?
So I'll answer this in a second. So we saw which patients, as we were saying, so it's only considered for patients with uncontrolled severe symptoms of allergic rhinitis who've had confirmation of allergy testing, and they've got inadequate control despite all the other measures. And the way it's administered, they can have it now sublingual, with a tablet, and some preparations can be prepared into drops or injection. And it's actually prepared based on, so they do an allergy test, and it's prepared specifically for each patient that they're allergic to their specific allergen. They aim to induce tolerance against the allergen, and they need treatment for up to 3 years. The sublingual injection, the sublingual obviously is the problem with the immunotherapy is that it can actually trigger anaphylaxis, especially more common with injection and less common with sublingual therapy. About third role of surgery. So surgery is actually allergic rhinitis is a medical condition, but surgery can give relief for patients who've got persistent symptoms of nasal blockage, where they've got examination, very hypertrophied inferior turbinate. And the key and the benefit of it is looking into reducing that submucosal fibrotic tissue, and then giving better room for the delivery of the use of the nasal steroids. So whenever you with surgery with patients with allergic rhinitis, they seem to think, well, it's going to that answer is going to cure everything, but just something that we do to optimize the use of the medical treatment. Different ways to do turbinate surgery, whether you do it submucosal blasphemy, use coblation, or use a microdebriding. So let's go back to the pathway. So I guess what do we do now once you see a patient? Well, I'm giving you too much information, and I guess you might be a bit confused now, but let's go on back to the pathway specifically. So we said we'll do a telephone consultation. We think they've got rhinitis, probably have some medical treatment by the GP. So you ascertain what medical treatment they've had and try to optimize that treatment. So this is our practice here at MRI, where we encourage them to use Theramar nasal breathing, and they can use it at least minimum twice a day, but they can use it 3-4 times a day. And they need to have a treatment course for 3 months. And then if they use, then depending on what medications they've had, use intranasal steroids or the Mista. And again for 3 months, 2 puffs in each nostril once a day. And then during that telephone consultation, you book them to have the allergy testing, if you want to confirm whether it's allergic or not. And then you offer them a 3-month follow-up. Okay? So then they'll come to, again, we're trying to get it into a one-stop face-to-face clinic. When they come to the one-stop face-to-face clinic, they'll have the examination, endoscopy, we'll look at their investigation, which is the allergy testing. And if they are, allergic rhinitis, we'll get them to do the visual analog score, to fill in the report outcome measures. And then they should have had optimal medical treatment for 3 months. So then depending on the outcome, if it's improved, then just discharge, no need for follow-up. We're trying to get it like a proper one-stop clinic. However, if they, have symptoms, clinically they've got a really big hypertrophied inferior turbinate, they've used the medical treatment, but still not an improvement, and have got enlarged turbinate, then we can offer them turbinate reduction surgery. They go through that route, they'll get a telephone follow-up. They don't need to come to clinic. And again, we can assess them using the patient report outcome measures. So that's why this is useful. So we can tell whether the fluid introduction surgery has made a difference, and if they've improved with discharge. They've got problems, we'll see them in the clinic. And then those who, I guess there will be another arm of patients who've got other symptoms, severe asthma, they've tried medical treatment for years, they've had turbinate surgery maybe in the past, or they've not got much, enlarged turbinate, then potentially we can then consider referring them to immunology. So this is answering your question, Erica. So you refer them to immunology, then they will see if they're candidates for immunotherapy. Remember, the majority of our patients will probably be, especially these ones, will be probably asthmatic, depending on the control of asthma, list of factors that would define their candidacy in the UK, whether they for immunotherapy. So the majority of the centres would immunotherapy is mainly delivered by immunology, not by ENT. So there's something to be,
Say if the medical treatment does help them,
but
it's once they stop it, they revert back to their symptoms.
Yeah.
Can they just restart the medical treatment, even if it's like a topical steroid spray?
Yeah.
So there's no risks with the topical
risks.
steroid.
Very safe, very highly safe profile. The only thing you'd ask about with nasal steroids, intranasal steroids, if they've got glaucoma. The only relative, even now relative, contraindication.
So doesn't it cause any mucosal thinning or anything?
No.
The question on rhinology testing, I think that the pathway,
Yes.
So which test you prefer for skin factor?
No, so RAST will do RAST. So measuring allergen specific IgE, because it's easy, and then
Second question, how to order
RAST. Really?
It doesn't exist a panel, you have to order one by one.
I've got
one by one.
Oh my god.
No.
That's why I keep looking for.
They don't have a panel. You have
no,
to
just a
say.
second. I type RAST on my Hive orders, and they come up.
Only for you then, because I've
Really?
never seen them around. You just create your own subset.
Well, you can create your own subset, but this is very odd
Okay,
because
you've done that.
I've not done that. I
You have
just
to type each
So you have to type everyone.
Can you share with us?
I've not created.
That's what I've done. I've
Really?
done that before, but I have to select each one.
I've not created a. But what I can create one and then share it with everyone.
Yeah.
But because for me, I type RAST and they all come up.
Yeah, it doesn't come up.
That's annoying. Yeah.
I have to do that.
I'll do that and share it with everyone.
Thank you.
Yeah, no problem.
And share with the people with us.
Yeah, of course. The other thing to mention, Rona, you're asking about the medication. Because sometimes we get lots of patients where they say, when you ask them, tell them about steroids, they be frustrated and say, I've used steroids, been on steroids for months, tried them for years, they don't work. One of the things that we should be doing on the clinic assessment is actually checking how they're using the steroids and how compliant they are. Because sometimes I'll use them, but they've been using them for a week. Doesn't make a difference when they stop it. And obviously, the steroids not going to be as
I'm the same.
Yeah, like oestrogen, for example, they give them an initial, relief. So this is really important, checking the compliance and telling them how to use the nasal steroids. Yeah, so
just use the right hand to do the left nostril and the left hand to the right.
exactly. So how I tell the patients is essentially if you're spraying your left side, use the right hand and aim the nozzle of the spray towards the ear. The problem is as well is that most of the steroids will have one of the side effects is it causes a bit of crusting. So if they deliver it onto the nasal septum, they can cause bleeding, and then you say, stop it because it causes bleeding. So the best way is to tell them to get their to strain the left side, use the right nostril. I always use a pen to show them. I don't have a pen now, but just essentially just to okay. So aim the nozzle of the spray towards the ear. Then if you're doing it on the other side, they swap hands and then again towards the ear. And not up, because most people will think their nose goes up, the nose goes back, so tell them always to aim towards the ear. And that's the way you should
steroid drops, like You'd like to start with the spray on
So for allergic rhinitis, I think using the intranasal steroids, the sprays, or the Demister because they will have because of the local antihistamine. But let's say if it's someone for chronic rhinosinusitis with a bit of rhinitis as well, then betamidol. So when we look into the chronic rhinosinusitis pathway, what we put in the pathway is when you're optimizing treatment, they probably have some steroids. They've had sprays, and you upgrade that into drops. But yes, so remember we talked on the in area guidelines that they've got persistent blockage. You can increase the dose of the spray. Let's say if you don't want surgery, you want other medical treatment, you can then consider using even oral courses of steroids for allergic rhinitis when severe persistent cases. It's in area guidelines, or you can use the drops as which are more potent.
Are there guidelines on what's necessary for people who don't know about all the types of
Yeah. So what do you mean? What kind in terms of? Yeah. So I think, but the thing is, if the mist is not good enough, if you look at the pathway, then they've got hypertrophied infusers, so just gonna get them into further. But yes, I guess here at that point, if you've done the telephone and if they've used that and they were compliant, use it efficiently, then you can try them on some betamidol as well.
I guess like if we call someone and they've already tried for many days for a long time, then what?
The thing is that the idea of the telephone is that we want to make sure those who come to clinic, they've had everything done because we want to make it a one-stop clinic. So let's say some of them might have not had anything. Some of them might have had already sprays and they're compliant, but they've not done an allergy test to get a panel. Remember, I appreciate some of that might be difficult. Some of them might have some, chronic rhinosinusitis type symptoms. They might have minor surgery, so it might not be very straightforward. And this is when we can talk about there will be a mix between the pathways. So this is not like a strict thing to follow. It's more of a guidance for us rather than something really strict.
Amr, can I ask please?
Yes, Tyson.
Sorry, I'm in the middle of a clinic, but I'm trying to catch up. Did you mention anything about polyps, or is this pathway only for turbinates and?
So this is yes. I'll go back to the full pathway. So this is This is on the blocked nose pathway. There is a different pathway for patients coming in with symptoms and history of chronic rhinosinusitis. So I'll get back to the start of the pathway. Okay, we are. But they're coming with this is the initial telephone, and on the initial telephone if you can, streamline them into these three pathways. So there's a separate one for chronic rhinosinusitis that we'll look into next time, I guess, because of sake of time. So those who've got a structural problem will go through that route.
No worries. I was just asking, have you thought of any thing to help us when stepping down patients from oral steroids to intranasal for polyps, I mean?
Yeah.
Or are we just dealing with chronic rhinosinusitis and allergic rhinitis for now?
No, we've got the pathway for chronic rhinosinusitis. I can share that. I can share it with you. I'll show you what it looks like.
Thank you.
This was the end of my presentation anyway. So, anyone got any questions about what we've done so far? Something to share it because it's I've got it as a Word document. I can share it on the WhatsApp group.
Is this the final?
This is the final, yeah.
Yeah, would you be able to share it?
Yeah, I'll share it. So we've got a document that we'll also share, and some of that the document will also have some information about the history taking again and what to do in the examination, what to find in the examinations. Everything will be It's not just that you've got a full document.
Amr, can I ask, as long as you're implementing something new in the rhinology clinics, are you thinking of any list for us to share and gather these patients to see if there is any change or improvement? I think this is a good project, and for us to stick to it, just create a list and we will add patients to it.
So I think that what Ms. Jason is working on with the management now is with the new rota that you're also involved with, Haytham, is getting because most of us are now doing head and neck clinics, so there will be people allocated to the rhinology clinic, and I think they will be more involved in doing that initial telephone consultation. So yes, of course, if we are gathering all the data and all the prompts, then that will create a huge potential for research, which I think will be great.
Yeah, thank you.
Thank you so much, Amr. That was very helpful.
Thank you.
I'm gonna stop recording now.
Yeah.
Habibi.
You go that in. You go that in the recording.
Forget why you record that.
Still recording. You know, I'm gonna record a lot of